right, thanks for coming. This is Dr. Corban. He is the one of our attendings in orthopedics. He specializes in upper extremity surgeries and sports medicine. So,
yeah. So thanks for everyone making out today. I had a small intro PowerPoint, but we're having issues connecting it, so it's not a big deal. But as Don was saying, my subspecialty training was first in sports medicine, so hip, knee, and shoulder. Arthroscopic stuff, soft tissue procedures. I did my residency here. I did my first fellowship at USC in Los Angeles, and then I did a shoulder and elbow fellowship at the New England Baptist Hospital, NGH in Boston. And so basically the purpose of this talk today is for shoulder immobilization and bracing, and then we'll talk a bit about elbows. Like, there's not so much for the inpatient group here in terms of elbow mobilization, but the shoulder stuff is something you're going to see. So Don's going to be our model here, and I was a model last time around. So these patients, at least the admitted ones, are typically going to have this for like reverse shoulder arthroplasty for fractures, also some elective shoulder arthroplasty patients. This is an abduction sling. So some people may come from the OR actually in a Stevenson immobilizer, but I do give a prescription for these for, they'll either have it the day of surgery or our brace guy will try and deliver it while they're here. Essentially, what the patients are allowed to do post-operatively is, pretty minimal stuff, but just moving their wrist in their hand, moving their elbow, working on pronation and supination, and then I do allow them to bend and straighten their elbow, but aside from that, not too much active shoulder motion. Really what I want them to avoid doing is I don't want them to do any active external rotation or any active forward elevation, because that puts stress on their tuberosities. And I try to repair the subscapularis muscle for the shoulder arthroplasty patients, so that puts stress on them if they do active external rotation. So I'll put this on you here. So this thing goes like this. There's two parts to this. So there's an abduction component and then the shoulder component here. So Nicola, our brace guy, is more slick at this than I am. So this essentially clips up like this. And then this goes around the waist. There you go. And that clips here. I thought it was snug on me. Both of us, I guess. So the purpose of this brace, and we kind of wear it back here, this is all adjustable, is to essentially keep the patients in abduction and external rotation. There's a lot of modularity to this thing, and you kind of need an engineering degree just to sort of figure out how to put it on. But this, if you roll this up here, it gives them a bit more freedom of the wrist, and if the patients are smaller, you kind of have to do that because your hand is covered. This position is desirable. It's a little bit more comfortable. It puts less stress on the proximal humerus and your tuberosity repair. However, I have noticed that in some bigger patients, this abduction brace actually can be uncomfortable. And if they're a little bit bigger, then actually they're kind of naturally in abduction. So if it's really uncomfortable, feel free to adjust this, or you can, in some cases, of taking it off, because the evidence for the abduction component is really, there's not strong evidence to show that that's better than a regular sling. However, it just, out of kind of common sense and biomechanics, it kind of puts less stress on the shoulder, so that's why it's ideal. But this doesn't necessarily fit everyone well, and I'd rather the patients be comfortable and not have any issues breathing than, be super strict with the brace wear. I do want them to wear some form of brace, and typically for the shoulder replacements, it's 4 to 6 weeks, depending on what I do. So during their admission in hospital, shoulder immobilization is important. Whether they're wearing this or the Stevenson, though, they'll have this in their chart. I sent a copy of this to Don, and they can basically do all of these activities. So that's pretty much it for the brace. I think so. You can see here at 2 weeks usually. What happens though is I do take this off, and this completely detaches. So this comes off. Yeah, and then you can basically just do this, adjust it for them. And again, if patients are really uncomfortable with this on the ward, you can take this off and just have it like that. Again, these braces are reversible, so for patients, a lot of the patients do have bilateral disease, so they can flip between having it on the left or the right side. So even if you take this off, have them keep it because they can use it for any future procedures or injuries down the line. So that's pretty much it for the brace wear. I think people were asking last time around about, how do the non-operative fractures do compared to the surgical ones, because I've been brought back to really do these procedures in patients who are over 65 or 70 who have proximal humerus fractures, particularly those who are like pretty active and healthy. So the literature definitely shows that there are better outcomes when patients who are active have a reverse shoulder replacement compared to non-operative management. Again, for patients over 65, it also shows that when we do overreduction trail fixation or hemiarthroplasty, the outcomes are worse than if we do a reverse shoulder arthroplasty, which is why it's becoming the standard of care for patients who are elderly. The definition of elderly is like pretty low in the literature. It's 65 years of age, so in older patients who have some level of function, because the functional outcomes are better after having the shoulder replacement done. And again, we were kind of discussing last time, like 80 today is not what it was necessarily 20 years ago. 60, calling a patient over 65 elderly is, to me, a little bit unfair, because most of the 65-year-olds I do see are pretty healthy and functional. And so it's a case-by-case discussion about who needs surgery or not, and it kind of depends on the fracture that they have. But if somebody is, somewhat functional, they do, they live independently, they have certain levels of activities that they do on their own, I think it's very reasonable to do this procedure, and there is literature and data to support that. So that's why we're doing that here. I don't think it was being done relatively frequently or at all for the last little bit. We're sending a lot of them to St. Mary's or treating them non-operatively. And again, in very frail patients, it's not wrong to treat them non-operatively. It's not like the lower extremity, like a proximal humerus fracture won't kill you, whereas a hip fracture will. So, if somebody is not a good surgical candidate, they'll have some function in their shoulder with a proximal humerus fracture. That, there's a well-quoted study called the Proffer study that was done in the UK, and it grouped all comers, but it wasn't RCT, and it showed that non-operative management is suitable for certain patients, but we do have an option for those patients who are quite functional, who want to use their shoulder and want to have good range of motion despite having proximal humerus fracture. So those are probably that's the majority of the patients you're going to see, and then some from my elective practice. The anatomic shoulder replacements, so the anatomic shoulder replacements are a little bit more reliant on the rotator cuff tissue, so I'll be more strict with the brace use in them. Those patients probably won't hang around very long though, because they're typically younger, they have to have intact rotator cuffs, they're healthier, they're not the ones that are going to be staying on the ward for too long. I think the ones you're going to see more frequently are these older, frail patients who have reversed fracture. And then for the elbows, I prescribe the patients a hinged elbow brace, but for the first 2 weeks, oftentimes they're just in a back slab. So for them, it's just like hand and wrist range of motion. There's really not too much to do for them. If you do see it, I kind of want to get those braces here so I can put them on them immediately post-op. But if they have it post-op, they'll usually be locked at 90 for the first 2 weeks, and then we start progressive range of motion. The elbow gets stiff though, so that's why I do encourage the hand and wrist motion for the patients who are wearing this sling, because the elbow is not very forgiving if it's immobilized for too long. So I don't want them coming in and they haven't moved their hand or their wrist for 2 or 3 weeks at their follow-up. I do want them to kind of get moving along. That's pretty much it. You guys can have it. This is for a patient that I'm operating on tomorrow, so I'm trying to get pizza on it. But you can have a look at it. There's multiple parts to it. It does often require a bit of adjustment. So patients may complain to you about so feel free to adjust it so that it's comfortable. It's really, you don't have to be extremely strict with it, but I want to just give pretty clear guidelines, because there are those patients who will not use it at all, and that can compromise some of the stuff that we do. So I'd rather that they wear it full time and be a little bit more strict with our directions. But for us, it's fine to just, make the adjustments so the patients aren't uncomfortable. Like one lady was saying that, this was making it difficult for her to breathe, and it was like pushing on her stomach. And, I took it off post-op day 2. I was like, this is, it's not worth that much trouble. Yeah, any questions or?
Does the hitch brace and the doctor brace have to be put on initially by the doctor, or it could be anybody?
No, so ideally I would have them available here, but to have them covered by RAMQ, basically I write a prescription and then our brace people, the ORL guys have been very good because they just come and do it for me. I have no problem with them putting on the brace. I mean, there may be certain cases of like, revision surgery or some where the repair is a little bit tenuous where I may prefer to put it on, but for most cases I have no problem with the brace person putting it on. And they can take it off for they can take this off for hygiene. It's fine for them. As I said, they can do elbow and wrist exercise. Light pendulum stuff is fine. So, taking it off or having somebody adjust it, I'm not typically, if I was, I would write that down. And in most cases, if it's that fragile, then we're maybe not doing the right thing for them. You know what I mean? Like it should be relatively durable so that they can kind of do basic activities. Any other questions? So Don has some stuff he's going to send out to you guys, and then if there's any questions, like Don knows how to get a hold of me. I'm sure there will be, and you'll probably encounter things as you see these patients. Usually, they'll most of the time have a block. So I examine them post-op, and then they're blocked by our anesthesia team. So it's normal for them to have some numbness and lack of sensation, and that's good at controlling the pain. This is not usually what is going to hold up discharge. It's like social stuff, not having access to rehab, stuff at the CLSC or whatever, awaiting conval. That's usually what's going to hold up the discharge of these patients. I had one patient who she had a history of Parkinson's and had a lot of pain, and she had that with her knee replacement as well. But the rest of them kind of get on a course for discharge and are usually out of here pretty quickly. And the elective patients, if they're healthy, this can be done as day surgery. If they're a little bit more frail, like a short admission overnight for a day or so. But the elective patients should be healthy enough to go home soon. If not, they're not really good candidates for elective joint replacement.
Soon as what, like 48 hours or?
Yeah, I mean, for me, it's like overnight, that'd be fine. And then I think the realities of our system, like if it's done on a Friday, they're not going anywhere until, Sunday or Monday. But yeah, I think that's, if they're medically fine, there's no reason to keep them in hospital. And it just puts them at risk of, nosocomial infection and all that. So I'd rather they're out of here, to be honest. And we're gonna start doing some at our outpatient surgical center, which is becoming more and more common because there's no real reason to use hospital resources for some of those patients. Yeah.
And typically, did you say you see them post-op day 2 weeks post-op?
Yeah.
Or
Yeah.
always?
Yeah, within 10 to 14 days post-op, wound check, frequently get an x-ray just to make sure things are in place, take out any clips that are present, dressing off, all that. Yeah, that's the follow-up. My Sonia is pretty good at teeing that up, but if there's any questions, it is 10 to 14 days post-op. And then they all get a copy of that sheet printed off for them, but if it disappears, I think Don has a copy of it now. We can also print it off and have it on the floor in case it just that facilitates things. And then I handle the prescriptions for the braces. There's other stuff, so as time goes on, revisions, all that, they will have pretty tailored physical therapy protocols based on what we do. When I say more tailored, it probably just means more mobilization. You know what I mean? For the inpatient stuff, it's just being more protective. So I don't think there's much more for you guys, but any deviations from the plan should be clearly written in the chart. Yeah. Any other questions? I think I'm coming back to do hip and knee stuff. I can give the intro. I'll send you the PowerPoint for that. I'll give the intro talk for that one.
Sometime in January.
Yeah, we can pick a date that works for. Yeah, we finally have our ORS. It's becoming a month at a time. So, because we're doing outpatient surgery at the center, so they kind of release the dates 1 month ahead. So we book stuff, and then I have moving clinics last minute.
That's okay. We appreciate you coming in.
Yeah, for sure.
Thank you, Dr. Corban.
Yeah. Yeah.